Good evening, everyone, and welcome back to the Primary Care Seminar Series hosted by the Primary Care Education Department at City St George's. My name is Roa Albaderi. I'm a GP and a clinical lecturer at City St George's. If this is your first time attending, welcome. The seminars run monthly during the academic year, aiming to cover hot topics driving the future of primary care, whilst also hoping to inspire interest and shedding light on the diverse career opportunities available in the primary care world. If you're interested, the previous seminar recordings are available on our website for you to explore, and there's a catalogue of topics including health equity, sustainability, migrant health, digital innovation, primary care in prisons, and so much more. So I'll leave a link in the chat following the seminar. Tonight, however, we're focusing on neurodiversity. It's estimated that 15 to 20% of the population are neurodivergent. And to help us explore this from the eyes of primary care, we're delighted to introduce Dr. Heidi Phillips, who is the RCGP Clinical Advisor for Neurodiversity and Associate Professor for Primary Care at Swansea University Medical School. She's the founder and chair of the British Association for Neurodiversity and is on the Clinical Advisory Group to Wales Government for Neurodiversity. The presentation will be followed by a Q&A, so please do use the Q&A box throughout the seminar to submit your questions, and we'll go through those at the end. So without further ado, I'll hand over to Heidi.
Thanks, Roa. Good evening, everybody. So I will immediately share my slides so that you are able to just see what it is that I'm seeing. So as Roa said, it's a little bit about me, a little bit about my career to date, and a little bit about neurodiversity. It's not intended to be a deep dive into all the conditions that come under the neurodiversity umbrella, but really to make you start thinking about why this is important to you and why this is important for all doctors, all clinicians. So it's really about just kind of opening our eyes to it and start recognizing that it's underlying an awful lot of what it is that we see in practice. So a few of my sort of disclaimers, if you like. As Roa said, I've got a number of sort of roles within this sector, and I have done a fair amount of speaking on the subject of neurodiversity. BAND is our organisation, the British Association for Neurodiversity, which is a national group of GPs. It's still predominantly GPs that have an interest in neurodiversity. Okay, so when I was training to be a GP, my supervisor gave me a piece of advice. He said, if you see a horse-shaped animal in a field, it's more likely going to be a horse than a zebra, because common things are common. So when you do your differential diagnoses, you start at the top, you start with the big name stuff, and it's the same thing. You're likely to be a horse, not a zebra. But this is really a story about zebras. So before I started medical school, I always knew I wanted to be a doctor. The fact that I wasn't particularly good at physics or chemistry didn't really dissuade me. I was determined that medicine was for me, but I didn't really know what field I wanted to go into. I hated surgery. I knew that. I hated standing for any length of time, and joining this bit to that bit really didn't appeal to me. But all the other specialties, really, I thoroughly enjoyed. Each time I did a new one, I thought I enjoyed it more than the last one I did, and I loved learning new stuff. I was quite good at physiology. And so for me at that point, a natural fit, I suppose, was to do an anaesthetic rotation, because I suppose anaesthetics really is applied physiology. And so that's what I did. I trained in anaesthetics. I loved it. I loved the lines, the central lines, the arterial lines, the blocks, the autonomy and the responsibility at a really early stage in my career. When I did anaesthetics, it was very much about, as an SHO, you were running the case, your consultant was in the coffee room. It seemed to me to be a fabulous specialty. And I loved the practical application of the physiology. But 6 hours listening to a machine that goes ping, And that was before the internet. That was when we actually had to talk to each other and to the patients. And I remember keeping patients out and awake and doing blocks on them just so that I could talk to them and I could really, have a chat and enjoy what it was I was doing. And it was during one session when we'd set up the case. My consultant was alongside me because it was a difficult case. And I got out all my books because I was studying for my primary exam. And he got out a load of books too. And I thought, what are you doing? And he said, oh, I'm planning my sabbatical. He said, I push all my holidays together in a year and I take a big chunk of them all at one time and we go traveling. And it was like an epiphany for me. I thought, I can't spend my day job planning my off duty. I love the learning. I love the new things. I love the novelty. But if it became constant and familiar and that I was doing something else, I thought I was going to get very bored and very stale doing just one thing. So I went into GP training. Rather reluctantly, I have to say at first. And I do remember thinking, oh, when I go back into anaesthetics, but I did 6 months of peds, I did medicine, I did A&E, I thoroughly enjoyed it. And when I finished my GP training, I was lucky enough to apply for and then be offered a job as a partner in my training practice. And at the same time, I applied to be a GP clinical tutor in the medical school. That was back in 2004, teaching clinical skills to medical students. I started off just 1 day a week in the medical school and worked 3 days a week as a partner in the practice. And during that time, I had my family, 4 children. When my third started school full time, I went up to 2 days in the medical school. So I was 3 days GP, 2 days clinical tutor. And it was only when my 4th child was born that I thought my work-life balance has to shift here a bit. I've got it the wrong way around. And so I switched it and I was 3 days in uni as a medical academic and 2 days in practice. And that was back in 2012. And that went on until probably 2017, something like that. My eldest was about 16, 17. During that time, we bought a small holding. I was a partner in my practice. I was specialising in diabetes at that point. I was teaching. I was doing various managerial roles within the medical school. I was working in admissions as well. I was busy, 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 and it suited my busy brain. In GP land, the revolving door, the 15-minute, 10-minute then, but 15-minute now, revolving door, it can seem daunting to many people, but for somebody with a brain like mine, it was essential. The difference of being able to see patient next, next, next. And as a GP, our role is multifaceted. We're diagnosticians, we're counsellors, we're confidants, we're sometimes even a lifeline. We navigate through that sea, if you like, of patient histories and symptoms and treatments, and each day is unpredictable. Each day is meeting new people, seeing new people, lots of challenges, lots of opportunities to make a difference, to work on multiple things at once, and to use that interest-based nervous system to be constantly wanting to move on to the next challenge. It works very well in general practice. Next, problem, solution. And it was only when my eldest daughter started experiencing significant mental health difficulties that I really started to try to understand what was going on. So depression, anxiety, they're used as labels. We use them as ends in themselves. Oh, you have anxiety. But when it's you or your child, trying to understand the cause of that depression and anxiety, we need to get beneath it. And in doing that, she went on to be diagnosed with ADHD. At that time, I fought against it. I really wanted to understand why on earth she needed a label. What good it was going to do for her. I didn't understand really why she'd want to put herself in a box like that. My amazing, vibrant, creative, intelligent daughter, my mini me. Interesting. It took a while for me to realise that ADHD and mental health difficulties aren't always easy to distinguish. They're tangled up in and amongst themselves, and sometimes so interconnected that it's really difficult to untangle them. If you think about it, growing up with neurodivergence can be quite traumatic in itself. Children who are neurodivergent can experience 20,000 extra criticisms, microaggressions compared to non-neurodivergent children or neurotypical children. And so they become traumatized in themselves, even as children. And so is it surprising that then they go on to develop mental health difficulties? So rather than trying to understand what is mental health, what is neurodivergent, what's going on here, it's really essential to listen to the patient, to hear their story and work out what matters to them rather than what's the matter with them. So a personal experience, but one that set me off down the path of wanting to really understand more about neurodiversity. So what is it? It refers to the whole spectrum of human neurotypes within a population. It encompasses both neurotypical and neurodivergent people. We're all neurodiverse, just like nature is biodiverse. So as an individual, I'm not neurodiverse, I'm neurodivergent. Neurotypical refers to the dominant neurotype or the dominant way of thinking, what might be considered standard or typical or average or boring. Neurodivergent individuals are those who show developmental profiles that deviate from the norm. So if you think of a normal distribution, they're at the sort of extremes of that. What we now know is ADHD is on a spectrum, that it's not you either are or you aren't, but that you're at the extreme of a distribution. So we've all heard of ADHD and autism, but what about the others? Neurodiversity is an umbrella term for a group of conditions that fall under the broader category of neurodevelopmental disorders. And if you want to learn a little bit more about it, you can look in the DSM, which is the Diagnostic Statistical Manual, version 5. It's available on the internet. You could also look at ICD-11, the International Classification of Diseases, and they will give you the sort of formal definitions of ADHD, autism, and all the other conditions under the neurodivergent umbrella. They include ADHD, autism, but also tic disorders, including Tourette's, and specific learning difficulties. So that includes dyslexia, dyscalculia, also developmental language disorder and developmental coordination disorder, which you might know as dyspraxia, as well as various sensory processing disorders, traumatic brain injury, and fetal alcohol syndrome disorder is also under there and presents similarly to ADHD. And the important thing to remember is when we think about diagnosing one or other of these conditions, we must remember there's overlap between them. And there are also several possible differential and coexisting conditions. Evidence shows that co-occurrence of neurodivergent conditions is the rule rather than the exception. And if we've got one, we're far more likely to have another. And the symptoms overlap as well. So now if I see somebody with dyslexia, I think, oh yeah, what else you got? And when you think about the symptom overlap, if you take a child, for example, with developmental language disorder, that's not something I ever learnt about in medical school. It's not something I ever learnt about as a doctor. But if you think about a child in a classroom who's got a language disorder. They might have a receptive or an expressive language problem. If it's a receptive language problem, they can't understand what's going on. They can't necessarily interpret and process spoken words very quickly. Or if they do, they process them at a much slower speed. Is it surprising then that their behaviour is effective? If they don't really know what's going on, they might play up. They may appear not to be paying attention. They may appear as though they have ADHD. And the expressive language difficulties, they struggle to find the words that they want to say. They struggle to express themselves. Imagine a young child who can't explain what it is that they're feeling or experiencing. You can see how that can cause frustration, which can present as a behavioural issue. So symptom overlap. When we look at DCD or dyspraxia, a child whose vestibular system's affected, they may not be aware of their body in space and the position of themselves. They're constantly readjusting. That's not hyperactivity. It needs to be distinguished from it. So when we come to distinguishing symptoms, we really need to understand all the conditions under the neurodiversity umbrella, and we need to remember the other conditions as well, like fetal alcohol and traumatic brain injury. So we do know that 15 to 20% of the population is neurodivergent. So this isn't a problem just for psychiatrists. GPs are the last of the generalists. It's a problem for all of us. Would it surprise you if I told you there's a Facebook group called the Association of Neurodivergent Doctors? When I looked yesterday, it had 2.4 thousand members. When doctors are struggling, they can be referred to practitioner health. It's almost like an occupational health service for doctors. Would it surprise you if I told you that of the doctors referred to practitioner health, between a third and a half of them are neurodivergent? Would it surprise you if I told you that general practice and anaesthetics has a higher proportion of neurodivergent doctors than other specialties? In reality, those of us with a diagnosis don't consider ourselves disordered. It's worth making the point that even doctors are neurodivergent. So how come we don't know about it? How come it's not obvious? The reason? Masking or camouflaging. We spend so much time during our working days hiding in plain sight. It is exhausting. It's not just about them, our patients. It's also about our colleagues, our friends, our families, about us. We know that masking's the key to coping in today's society, but it also is associated with mental health problems. So take a look at the wording that's found in the various classification systems that the medical model of neurodivergence supposes. This is a collation. It's not, if I was to look up ADHD in the DSM or I was to look up autism in the DSM, it would give similar wording. So deficiencies, limited capacity, impaired, deficit, restrictive. Clearly, doctors don't identify with that impairment model. So many people now advocate for the social model of neurodivergence. So terms like disorder and deficit better reframed as differences or difficulties. And this is all part of the development of the neurodiversity movement. And that's essentially a reframing of the medical model to the biopsychosocial model and the use of neuroaffirmative language. So moving from deficit, disorder to difference, to understand that for people who are neurodivergent, othering them is insulting and hurtful and contributes to mental ill health. So you know that 15 to 20% of the population are neurodivergent. Undiagnosed and unsupported neurodivergence is linked to poor mental health and physical health outcomes. It often coexists with mental health conditions such as depression, anxiety. It often underlines depression, anxiety, and other mental health conditions. it's often mistakenly labelled. In fact, the DSM and all the diagnoses in the DSM preempted and predated a lot of ADHD and autism. And so now when I read things like emotionally unstable personality disorder, that is a disorder apparently predominantly affecting women, I do wonder if they're actually mistakenly labelled neurodivergence. So we also know that it's not just mental health. There's increased prevalence of physical health disorders as well that can coexist and co-occur with neurodivergence. And there's the substantial overlap between all the disorders. It's really common for individuals to exhibit traits or receive diagnoses for multiple neurodevelopmental differences. And we know that many conditions under the umbrella co-occur. So the likelihood of having one increases the likelihood of having another. So when you see one, you should be alerted to the possibility of others. It's common for individuals to exhibit traits or receive multiple labels. And actually, sometimes the label you get depends upon the door you go through to get it. Co-occurrence of neurodivergent conditions is the rule rather than the exception. So it really makes little sense to screen for them separately. If someone comes in saying, I think I might have ADHD, then it's worth thinking about the other conditions under the umbrella as well. When you think about how the referral pathways work, it makes so little sense to be referring, oh, you think you have ADHD, we'll refer you to that pathway, but you've got autistic traits as well, so we'll refer you to that pathway. And actually, so much of it overlaps and so many of their symptoms overlap too. I'm sorry, the slides are just flicking onto the next slide. So yeah, think about the sort of inefficiencies in the waiting list and the inefficiencies of resources because of the way we're currently set up in terms of providing services. Now, you know, I said that neurodivergence is linked with physical health comorbidities as well. Neurodivergence actually forms part of a wider collection of interrelated health conditions. And these include connective tissue disorders, including joint hypermobility, Ehlers-Danlos, dysautonomia, so things like postural orthostatic tachycardia syndrome, POTS, autoimmune disorders, chronic pain, chronic fatigue, many gastrointestinal disorders. There's such an overlap between them. We also have bowel dysmotility, epilepsy, migraine, and others. Researchers identified links between all of these, mediated, we think, through mast cell dysfunction as well. So we get increasing asthma and increasing allergies in the neurodivergent population. So it's not just about heart sync ADHD or heart sync autism. Oh no, how do I deal with this? All those patients for whom we struggle to understand what's going on are likely to have something going on if we just scratch beneath the surface. What could it be? Think ND. Sometimes these complicated problems, these complicated patients, which include the social, the behavioural, the medical problems, are actually comorbidities of the main problem. And the underlying problem's hidden, it's camouflaged. A process that we call diagnostic overshadowing. We focus on the depression, not the cause of the depression. We need to shift our mindsets to see comorbidities as a pointer that there's something else going on. We wouldn't diagnose heart failure without wanting to understand the cause. Why are we doing the same for anxiety and depression? So why is it important for you to know about it? As a GP, I'm the last of the true generalists. We see the whole person, brain and body. And neurodivergence covers the whole lifespan. It connects physical and mental health. It's heritable and it's heterogeneous. ADHD is more heritable than height. We're increasingly recognising that underlying neurodivergence presents when people's strategies for coping fail. So when demand exceeds capacity. That's often at lifestyle transition points. So transition from primary to secondary school, or from secondary school to college, leaving home, starting a job, starting a family, menopause. The structures and strategies that we use to cope often fail us at those times of transition. And yet current healthcare teams aren't provided or aren't set up to provide holistic care that addresses all the interconnections. Where patients are referred depends on how they present. And patients are often repeating their story over and over again to different members of the various healthcare teams. There's a lack of effective communication among the services, a lack of joined up working. That picture, that image could also represent the waiting list, couldn't it? That if you get referred at the beginning, you could be at the end of that before you actually get seen. It's also worth remembering women and girls. Diagnosis is often late because neurodivergence presents differently in women and girls. Diagnostic criteria are based on the male presentation. Remember that estrogen is dopaminergic, and this can affect the difficulties that neurodivergent women face at various points in their lives. ADHD might present for the first time during a major life transition, like puberty, childbirth, menopause. And data published in a study in 2023, based on a study of 209 women with ADHD, showed that in every episode of hormonal change, so menstrual cycle, postnatal, menopause, there was a 2 to 3-fold increase in frequency and severity of the mood changes. So it is everybody's problem. And if we go back to GP land, GPs are overwhelmed. There's no room at the inn. There's no service to refer to. Services are overwhelmed. Wait lists for autism and ADHD assessments are up to 18 years long. Is it surprising that GPs are saying, we can't do this, we're pushing back, it's not our problem, refer to psychiatrists? But it is our problem. Neurodivergent patients represent a significant proportion of the number of patients that are seen in primary care and in A&E and in whatever specialty that you wind up going into. So we need to rethink ADHD and neurodiversity. We need to understand that it's a system that affects all of us, mind and body. And we also need to understand that when patients come to see us, often it's not for medication, it's not even for a label, it's because we're struggling and we need help. GPs are asked to take on many new shared care patients, often with private providers. There's no funding, there's no new funding. And GPs in the UK provide care for their population of patients. They receive about £165 per patient per year. That's as many times you want to see your GP. GP is free, and you can have as many appointments as you need. And they're not commissioned to look after neurodivergence. As Wes Streeting pointed out in his speech in the conference in October, there are 1,500 fewer fully qualified GPs in the NHS today than 7 years ago. And whilst hospital productivity has fallen in the last 10 years, the reverse is true for general practice, and we're delivering 32 million appointments, more than 5 million more than 5 years ago, with fewer GPs. Requests for assessments for neurodivergence are soaring. Diagnoses are soaring. Awareness is soaring. But there's no evidence that prevalence is actually changing. There's more awareness amongst GPs, trainees and medical students who are also recognising that we identify as neurodivergent. And recognition, identification and acceptance is just the start of the journey towards deeper understanding. The debate often focuses on whether diagnostic thresholds or standards are dropping, rather than actually addressing the patient needs. Why are they all coming to see us as GPs? Because they're struggling. Remember that zebra? Imagine spending your whole life in a field full of horses, trying to look like a horse, trying to act like a horse, all the time suspecting you're not a horse, and all the other horses know you're not a horse. And then one day, someone opens the gate to a field full of zebras, and you can look down and you can go, oh. And better still, all the other zebras welcome you with open arms. Come on in. They recognize you as one of their tribe. Imagine realizing you're not a failed horse, but you're actually rather an amazing zebra. That's what my daughter said to me when she was given her diagnosis. Most patients aren't seeking a diagnosis because it's the latest TikTok craze. They're seeking a diagnosis to be able to make sense of their difficulties. So, what can we do about it? What's the answer? We need to reframe neurodiversity. Instead of, oh, not another one, think about the difficulties that patients, that your colleagues, your family, or even you experience, and then maybe reframe them. Maybe look at them through a neurodivergent lens. Those patients that are frequent flyers, who you never seem to be able to get to the bottom of, the repeat offenders, the recurrent DNAers, those who appear to be known to all departments, those who have communication difficulties. And just touch on that a minute. Communication difficulties. Communication is two-way. It's worth remembering that. So if there are difficulties with communication, there's two people responsible for that communication. It's not all down to one. Think about those appointments where you just think, what happened there? I'm a great doctor. I'm a good communicator. That interaction just didn't work. That didn't go as I expected. Rather than heart sink, maybe we ought to rethink. This is a study by Libutsky in 2024, and he used a database of nearly 5 million people in Germany, including 87,000 with ADHD. And they found a significant association with Parkinson's, restless leg syndrome, sleep disorders, fibromyalgia, and the other conditions you see on that. So instead of that feeling when someone comes to see you with that familiar phrase, I think I have ADHD, think, really? And start digging deeper. But it's also worth thinking through the other side of that lens, all those patients with the chronic conditions that you struggle to know how to help them. Rethink them, reframe them. Maybe start thinking possibly neurodivergence might underline it, and suddenly a lot might start to make sense. So how can you tell? What can you do? How do we actually help them? We ask how they experience the world. So this is a framework that was written up by Mary Doherty in last year. She calls it the SPACE framework because a lot of people refer to the autistic space, and I've adapted it a little bit to make it relevant for the whole of neurodivergence, not just autism. So SPACE, sensory input. When we think about the senses, we think about all 7 senses. So that's sight, smell, taste, touch, hearing, but also proprioception and interoception. So when you think about the senses and you think people who maybe don't experience pain the same way, maybe don't actually show on their faces that they're experiencing pain. Maybe those who have sensory differences, their preference or aversion to sound, taste, textures, smells. Combine that with somebody who struggles and may be overwhelmed My daughter, when she was little, you couldn't put cotton wool on her skin. She would absolutely freak, and we didn't realize it was a sensory aversion to the texture of cotton wool. My son, who's also autistic, can't be on a beach. His behavior when we go anywhere near a beach when he was a child was an explosion, and we thought it was a behavioral issue. It was only when he was grown up he was able to tell me, "Mum, it's like bees. I have bees under my fingernails, in my ears, in my nose, in my mouth, behind my eyes. That's what happens to me with sand, seeing, imagining, feeling, being near sound." It's a sensory wiring issue, and that's why they process sensory things differently. So thinking about that with your patients, don't make assumptions that whack this plaster on, that'll be all right. Ask, they may have sensory differences. And the social side of things, hobbies, interests, intensivity and longevity. So do they have deep and special interests that really matter to them? The stereotypical boys and trains is not seen in girls, but actually makeup, hair, horses, pop stars. I'm not talking about a fleeting poster on the wall. I'm talking about a deep, immersive interest that all birthday parties, themed, etc. That might start making you think, neurodivergent. What about high adrenaline activities, solo activities? What about friendships? Knowing how to initiate, manage and repair friendships, managing in a social situation. Social communication differences would make me think neurodivergence. And under P, the processing and the planning. We often struggle to know what we need to be doing and what we don't need to be doing. We often focus on what's immediately in front of us, what gives us the most reward, the most stimulation. Process of trying to work out priorities can be overwhelming for autistic folk as well as those with ADHD. We sometimes get bogged down with the detail and we can lose sight of the bigger picture. We can get distracted and focus and hyper-focus on an irrelevant area, meaning we run out of time or we get our days mixed up. This can have a knock-on effect on other tasks we need to complete during the week. So prioritization, procrastination, management of time and self. Then on to A, and attention. What holds your attention? Fleeting attention, flitting from activity to activity, or hyperfocus, attention to detail, learning, memory, organization, remembering things, losing things, organizing things, all comes under attention. Communication, our own and others, use of language, whether we can actually seek help, whether we can find the words, whether we can explain our thoughts. Emotional dysregulation in children is because they can't express what it is they're feeling. Autistic children have a sensory overwhelm that they can't actually express what's happening. They just go into a meltdown. And conversation, when we think about humour and meaning, often autistic people may have a literal interpretation of meaning, so that not necessarily understanding idioms or humour. If I say to my son, "Have you seen my hairbrush?" his answer would be, "Yeah." And if pushed, he might say, "It's black, Mum." I've asked him the wrong question. I'm asking, "Do you know where my hairbrush is? I've lost it." But that's not what I asked him. I said, "Have you seen it?" And they often literally interpret the questions. If I say to him when he was little, "Would you like to put your coat on?" When he says no, he's not being rude. He's just answering the question. So blunt, honest, factual. And in ADHD, often tangential, often going off on tangents. So you start telling a story and you get distracted by your own thoughts and you wind up having wonderful tangential conversations that never actually get to the point. That's conversations in our family. Understanding the rules of conversation, the ping pong of conversation, the asking about the other person, back and forth, social cues, overtures, facial expressions, tone of language, body language, the discrepancy between what it is I'm saying and my use of gestures, my use of pauses in the conversation. Those may not be seen in somebody who's autistic. thinking about eye contact, intense or fleeting or just unusual. And then on to the E, the emotions, processing, expressing, understanding and recognizing emotions. And from an energy side of things, is this the need for movement, fidgeting, fiddling, squirming about in your seat, excuses to leave your seat, tapping your leg, bouncing your leg, swinging on your chair, talking excessively, motor movements, tics, thinking and acting in the moment, shouting out, talking over, butting in, taking turns, not considering consequences. And another E under that might be executive function, being able to think, plan and carry out and reflect and back and do it again, rather than just focusing on what's in front of you. So that's a massively quick walk through some of the differences that might alert you to the fact that somebody might be neurodivergent. So how did I start? I wanted to know more about it because of my daughter. So I got in touch with a local clinic and I said, can I come in and sit in with you? So I approached the local ND disorder service and said, can I see what it is you do? And they spotted me and thought, GP, wide range of skills, holistic approach to patients, huge knowledge of drugs and interactions, experience in clinical reasoning, very, very time efficient. We also use our general skills, and we're used to being part of MDTs and multidisciplinary teams. We can also do things like interpret ECGs and examine patients. We're entrepreneurial and we see systems that can be improved. And that's where development of a special interest came in. So I started by setting up a Facebook group, GPs with a special interest in ADHD. And then I went on to set up a WhatsApp group called NDGP, not for neurodivergent GPs, but for GPs with an interest in neurodevelopment. But actually, probably quite a number of us on that group probably do have zebra stripes. And then I went on to set up the British Association for Neurodiversity, BAND or B4ND. It's a UK-wide organisation for clinicians with an interest in ND. It's a not-for-profit membership organisation, and it started by just pulling together a group of GPs saying, what do you think? Should we be doing something about this? Should we be doing something about the fact that we need to be spreading the word about neurodiversity and teaching people and telling people about it? So we've expanded to basically include all GPs and anybody else who's wanting to be interested in joining. We've got members from all over the UK, practice in NHS and private. We've got training programs, LMCs, etc. And we're now over 300 members, and we ran our first course in neurodiversity in January for GPs who want to develop a special interest. We've set up a framework for a GP with extended role or GP with special interest for neurodiversity in ADHD. And we've got a special interest group within the college of GPs that's also related and to do with all those GPs who are interested in neurodiversity. And the new VTS curriculum should be coming out shortly if it hasn't already. And it's got a section for neurodiversity that we wrote for the curriculum to basically highlight the fact that this is something that everybody needs to know about. So that's a very, very quick run through. I'm going to stop sharing if I can find out how to do this and hand back over to Roa.
Thank you, Heidi. Thank you for walking us through your personal journey with such clarity. You've sparked quite a conversation in the Q&A, so we'll jump straight through the questions. So starting off, the first question, a hard question. Do you think bipolar disorder and ADHD diagnostically get mixed?
Absolutely. That's an easy answer to a difficult question, but yes, a lot of disorders under the DSM we've got to be really careful about what we're diagnosing and really making sure that we listen to what's happening there. We can go into the ins and outs of how to differentiate between all of the differences, but I would just direct you to the ICD or the DSM. There's also a really useful website called Compass Psychology, where they have a lovely sort of spreadsheet that says these are the differences. But actually, that's very much down to the DSM. And as I hope I've highlighted, that probably needs to be looked at now that we understand neurodivergence so much better and think, is that a diagnosis in itself? I mean, let's think about a diagnosis like oppositional defiant disorder. Is that a thing? Or is that actually pathological demand avoidance under the autism spectrum? So it's about looking and listening and really understanding the patient's experience.
Thank you. Next question. Differentiating between the different neurodiversities during a first presentation in primary care is a challenge and often favours a deficit model of consultation. And you can feel ill-equipped to do this in 10 to 15 minutes on a backdrop of 1 or 2 year wait lists for assessments. What would you prioritise for a first consultation in primary care? And how can we best support patients in the community whilst they await assessment?
Wow. Okay. So it depends on how they present, I think, for me. So if they come in saying, I think I might be neurodivergent, or I think I might have ADHD, or I think I might be autistic, that might be a different conversation to if they come in saying, I've got all these problems to do, and you're thinking neurodivergence. And the two have to be approached differently. If you're thinking neurodivergence, then it is a very gentle, very suggestive response that is not going to be necessarily done in a 10-minute consultation. It might be just, have you ever heard of? I certainly use my own personal experience. I'm neurodivergent. I have a diagnosis of ADHD and I have a beautifully neurospicy family. So I actually say, well, I have ADHD and some of what you're describing really resonates with me. Have you ever thought? But obviously that's not something all GPs can do. If you're somebody where they come in and they say, I think I might have, then actually having a look at the band website and seeing, is there somewhere you can direct patients to actually do some homework, depending on what you think's going on, to have a read and to have a look and to have a work around what things they might be thinking of. And then there's lots of resources out there that patients can actually address and access and do the questionnaires, do the things themselves outside of that 10-minute consultation, and then arrange to see them again, come back and see and say, what did you think? Did anything make sense? It's a bit like religion, I think. If they say, oh no, absolutely not, fine, leave it alone, that's not one to touch. But if not, then it's something to explore and it's a longitudinal conversation.
Thank you. Next up, you mentioned mast cell dysfunction. How strong is the evidence, and is there a case for mast cell stabilizers or antihistamines?
That's a very good question. I'm not the person to ask. If you're interested, there is Dr. Bendy Brain, who is Jessica Eccles, who is a leading researcher in this field. She's based in Brighton. There is a website called Embracing Complexity, and that is pulls together lots of research articles on that. There is also a webinar coming up with a consultant psychiatrist on the 27th of February with attitude.com, which is it's US centered, but it's a really useful resource for neurodivergence. And he is doing a webinar on the interactions between ADHD and complexity and mast cells and things like that. And I'm going to be going, so I'll be more equipped next time.
Brilliant. I'll pull together all of those resources you've mentioned in an email for anyone interested as well. Okay, next up, how do you address the patient's fear of labelling?
That is such a good question. That was me. That was me with my daughter. Stigma. I don't want to be thought of as autistic because of the negative connotations. I certainly didn't want my 14 A-star, IB, A-level, degree level, wonderful daughter to be labelled in that way. But You don't necessarily need to be. It's about understanding that experience. So actually identifying with the the characteristics and the experiences of somebody who's autistic or somebody who's has ADHD, and actually thinking, gosh, that's me. I recognize that, I have that, I experience that. Whether you decide to do anything about it or not, surely knowing yourself and understanding yourself, and then recognizing that you're not alone and that other people have these same experiences, can be so freeing and really, really helpful.
Thank you. Alex asks, what do you think about the role of trauma? Thinking of Gabor Mate's book, Scattered Minds, for example.
It's an interesting question because, as I sort of alluded to, trauma is very much part of all of this as well, because not only is there the trauma of those microaggressions from very early age, but intergenerational trauma that happens. So we know that families beget families of neurodivergent people, and actually if you come from a family that is struggling to cope, that doesn't have the strategies that can cope, that doesn't have the resources and the scaffolding, then actually you can see that it's a self-perpetuating problem. So where one ends and the other begins is sometimes, as I said, with mental illness, it's really difficult to just disentangle.
Yeah. Somebody's asked, I may have heard wrongly, but I think you said your daughter was diagnosed with ADHD around 17. Did she show symptoms of ADHD in the childhood and teenage years? Being a medical or GP parent, any advice on how best to manage that? Did ADHD come to mind in her early teen years or only later on?
Okay. When it is your lived reality, when every day is the way your day is, then you don't actually realize, you think you're a failure as a mum. So I never made it to parents' evening because I could never get organized in time. Things like what do they call them? Harvest festivals, when your children have to take in beautiful presented bowls of fruit, and my kids would raid their lunch boxes for an apple because mum had forgotten. All of those things, because those were our realities. We didn't really realize that that was a thing. We just thought it was us and we were pretty useless. And we managed and we cobbled together, and we had strategies and structures, and we had Alexa in every room in the house, and we have a key drawer, and I took it off here, but you probably saw when I started Row, a huge write on wipe offable board so that we remember who's got to be where and when. All those structures and strategies that we had, because we had to have them and we didn't realize. And then it was when she left to go to college and she didn't have those strategies and those structures and that support, that's when the wheels fell off her cart. So no, at the time, did I think? Absolutely not. With the retrospectoscope and then looking back on my childhood and going, that's why that was. And my mum telling me the stories and seeing those stories through a ADHD lens and going, it all makes sense.
Next comment, thank you for such a clear, informative talk. Do you find a connection with transgender patients and neurodivergence, and how do you navigate this?
That's really useful. That is a political hot potato, as you can imagine. If we start saying that autistic people are transgender, or you're starting adding to the labeling, the traumatizing, the microaggressions, but absolutely the numbers of patients presenting to transgender clinics who are neurodivergent are huge, but we haven't got the figures to support it.
Question from a student, is there any role or way for students to get involved with band?
Yes. Go on the website, have a look, have a poke around, see what you think. And yes, by all means.
Brilliant. And how can we support our neurodivergent colleagues in the clinical setting?
I think about that space framework. Think about the difficulties they might be having if they're out as neurodivergent and they're quite vocal and open about it, then have discussions to understand and learn from their experience. If they're not, then think about what difficulties they may have. As an ND GP, I didn't know I had ADHD, but I knew that I had to do today's work today. I knew that if I went home at the end of the day, it would go. I would have no recollection the following day of what work I had left over from the day before. So I would be the one that started early and worked late because I had to get it all done in one day. Recognizing the colleagues who perhaps are staying late and starting early, perhaps the ones that are running late, perhaps the ones that are falling behind on their paperwork, perhaps the ones that are never actually able to stop for a cup of tea, things like that, and thinking this may not be because they're useless and inefficient. It may not be because they're lazy or they're just delegating, dumping, whatever. It could be. I'm not saying it's not, but actually seeing it through a what difficulties are they having and what could we be doing to help that? So my brain meant I was fab on call. Absolutely. Give me a Monday morning on call. I was fine. But paperwork, oh my goodness me, sitting there and writing those reports and those letters. So if somebody hated on call and would do my paperwork, that would have been a match made in heaven. So actually working out on your strengths, and because we've all got strengths and we've all got challenges, and it's working to our strengths.
Brilliant. May have missed this if it was mentioned before, but are there any support groups for neurodivergent medical students or doctors?
Yes, so the Association of Neurodivergent Doctors that I posted up, if you go on Facebook, Association of Neurodivergent Doctors is one. There is Autistic Doctors International, which is another, and there is DING, which I've forgotten what it stands for, Doctors International Neurodivergent Group or something. That was another group that's been set up. It's slightly smaller, I think, than Autistic Doctors International, but it's along the same thing. So yeah, have an explore.
Thank you, Heidi. I think we've got time for one more. Thank you for sharing your personal stories. Can you share the genetic versus environmental weight as factors leading to a diagnosis?
Not the weight, but just well done for recognizing that it absolutely is. That it's where does one start and the other begin? We know that genetics leads to epigenetics, that genotype promotes phenotype. So actually the genes we are means the way we act, which then influence the genes of the next generation, and one interacts with the other. How they're weighted, we don't know. We know that both contribute.
Brilliant. Thank you so much, Heidi, for your time and for answering those questions. I'm just going to do a few announcements before we end the session today. If you bear with me one moment. So we look forward to seeing you again on the 25th of February for our final seminar of this academic year. We'll be joined by Professor Willie Hamilton, exploring cancer diagnosis in primary care. We really welcome and value your feedback as we continue to develop the series. So please do use the QR code on the screen, and a link will be sent to attendees in due course. And I'll try and collate all of the resources that Heidi's mentioned in her seminar today and pop that all in an email to you all. Thank you all for joining us and hope you have a lovely evening.
Thank you.